All right. Here we go. Good morning, everybody. Thank you for being here. This is the Quality and Patient Safety Committee of Cook County Health. Welcome, everybody. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And in order to streamline the proceedings, we've combined the action items into one combined motion so that we'll only have one roll call vote towards the end of the meeting. And meetings will continue to be held remotely unless otherwise noticed due to the determination this public health emergency continues. So, Debbie, if you would call the roll, please, we can convene.
Director Garza?
Present.
Director Prendergast?
Present.
Director Story is absent. Chair Guggenheim?
Present.
And for the record, those directors also present. Director Harrington?
I think he's muted.
Present.
Thank you. You have four.
The next meeting will be held on Friday, the 18th of March at 10:30 a.m. Do you have any public testimony for us?
We do not.
Right. In that case, we'll proceed to item 3, which is a report on quality and patient safety matters. And first of all, we're going to hear about the High Reliability Organization dashboard. And I believe, Dr. Fegan, you are going to discuss this with us, are you?
Yeah, that's correct. Thank you.
Thank you. Please go ahead.
Yeah, we can go to the next item. Yes, this is our 30-day readmission rate. So these are unplanned, all-cause readmissions to Stroger. The 30-day readmission rate increased between September and October, and this was driven by increases in oncology and orthopedic service lines. The highlighted box you see on readmissions rate for Stroger decreased since 2019 across all patients, and Stroger falls just below the benchmark for safety net hospitals. And in evaluating readmission rates for heart failure patients, not only has Stroger improved the readmissions rates between 2019 and 2021, but heart failure readmission rate performed significantly better than safety net. The safety net benchmark. And the HRO readmissions group was focused on transition of care and targeting patient education at the bedside, directed at patient self-management post-discharge. And so the team continues to its efforts aimed at post-discharge follow-up appointments with cardiology or a primary care physician within 2 weeks of discharge. And the HRO work group is assessing the guideline on concordant care to address all of the needs of the heart failure patients. And so the readmissions work group will be presenting to this committee in March. But I think it's because of those focused efforts on heart failure patients that we saw this improvement in heart failure patients in general. We can go to the next one. And so this is the case mix index for in medical cases. And the medical CMI decreased slightly between October and November. The target goal was met in November, and Stroger outperformed the Vizient mean for comparison hospitals. And so the decrease was attributed to fewer comorbidities and complications that were captured in our documentation. So when we remind our docs about the documentation, they get really good. And as they drift from that time when they were reminded, we tend to slack again. And so it's a need to sustain it. And so with medical cases, the fewer comorbidities and complications that were captured in the documentation results in the fall. So as in the highlighted box, the case mix index for surgical cases, I'm sorry, I'm getting ahead of myself. So we discussed in the last meeting the case mix index that had improved significantly since 2018. And in the last 12 months, as in the highlighted box, the case mix index for medical cases has remained consistent in non-COVID patients. So we will talk about our tactics when I go to the next slide. So we can go to the next slide. So this is the case mix index for surgical cases, and the case mix index in surgical cases decreases significantly between October and November, and it didn't meet the target or the stretch goal and fell below the Vizient benchmark mean. And so, as with the medical cases, there were fewer comorbidities and complications that were captured in the clinical documentation. And so, in the highlighted box, the case mix index for surgical cases improved in the last 12 months. The HRO clinical documentation group continues to work with the clinical documentation improvement specialists in the physician queries. So in December and January, the work group targeted several service lines, including trauma, surgery, cardiology, OB-GYN. In addition, the HRO clinical documentation team will be evaluating our sepsis documentation. So we're meeting with those individual departments and trying to provide the support and really work with the providers to help them understand the things in documentation that are so important for helping us to hit our targets. We can go to the next slide, please. So this is the patient experience. This is the top box score for recommend a hospital in the HCAP surveys for Stroger. The likelihood to recommend the recommend measure for Stroger has increased between November and December and is improving to the 50th percentile. As is highlighted in the box, there are several important improvements that were noted in the fourth quarter of 2021. All of the measures associated with discharge information and effective communication on discharge to avoid hospital readmission show significant improvement. And our new Chief Experience Officer, Ling Dang, will be presenting to the committee today. And we can go to HEDIS, and Dr. Irons will talk about HEDIS.
Thank you. Please proceed. Yeah.
Okay. Yes, thank you. And thank you, Dr. Fegan. So good morning, everyone. I'm Sharon Irons, Medical Director for Ambulatory Services, and I'm presenting our HEDIS metrics for diabetes and childhood immunizations. Next slide, please. Oh, right there. Go back. Okay, thank you. So you'll note that at the top of each graph, we are reporting in-care patient data. In-care patients are those who have accessed our medical homes at least twice over the previous 2 years. Therefore, patients who are out of care are those who do not fall into this definition. And actually, they are a very small percentage or negligible portion of our population. In fact, for both our diabetes and child less than age 2 immunizations, the out-of-care population is less than 1%. This slide actually demonstrates 3 important diabetes metrics that we've been monitoring for 2020 and 2021. The first measure is hemoglobin A1C screening, often just called A1C screening. This indicator tells us how Cook County Health is performing and monitoring how well our diabetic patients are doing. The A1C gives us a picture of how our patient's diabetes is under control. So when a patient's A1C level rises above 9, that corresponds to suboptimal or poor control. So this first set of bars on the graph demonstrates what percentage of our patients have had this level checked within the previous year. In the year 2020, it was 93.2% of our patients, of our diabetic patients. And in 2021, that percentage fell somewhat to 88.2%, primarily due to the COVID pandemic, where fewer patients were accessing the healthcare system in person and coming in to have their labs drawn. So our target was to screen at least 91% of our patients. The second set of bars tells us what percentage of patients who underwent this A1C test and had an A1C greater than 9, which is an indicator that the patient's diabetes is poorly controlled. So this is an inverse metric, meaning that you want that percentage to be as low as possible. So the lower the percentage of patients poorly controlled, the better the overall overall diabetic population is that you're serving. So in year 2020, we were at 27.9%, and in year 2021, 27.7%. Our target is currently set at 24%, but was at 32% the previous year. So that means that we met our 32% goal, and we've revised our target to 24%. To put all this in context, we are performing extremely well on this target. Compared to other health organizations looking at managed care benchmark data, we are in the top 10% of performance on this metric. So even when we hit our target of 24% or less of patients poorly controlled, then we move into the top 5% of performers. The last indicator on this slide is nephropathy monitoring. This tells us how well we're doing in monitoring the kidney function of our diabetic patients. It is important to monitor the kidney function in diabetic patients because when that function is affected, patients will often need to be on certain medications to prevent further loss of that kidney function, which, if left untreated, may eventually lead to the patient being placed on dialysis or to an early death. So this is another way to keep close tabs on how our diabetic patients are doing. As you can see here, we were at 93.7% and 93.9% in 2020 and 2021, with the target of having 92% of our patients monitored. So again, we are doing well on that metric. Next slide, please. So this slide is just a breakdown of the same information, but by health center, showing us how the individual health centers are performing on the metrics. This is Q3 and Q4 is on the next slide. This allows us to drill down and see which health centers may need extra help in getting the goals that we've set. We also share best practices from one site to another. For example, you'll note that we've placed the centers in alphabetized order. So we look at Core, Cottage Grove, and Robbins, who are the top performers here, and have them share what their practices are with the other centers. We also try to identify barriers, as in the case of Prieto. We recognize that we have had some staff turnover, and whenever that happens, patients have more difficulty accessing the site for their routine care. So now we're really obviously having to focus on staff recruitment for that center. Next slide. Again, this is similar information, but shows the data for Q4, and it's not substantially different from Q3. Next slide. Childhood immunizations. This is a metric that we follow in our pediatric population. Specifically, it is a measure that tells us whether our children have received the composite or panel of all the immunizations that they're supposed to have by the age of 2. And as you can see here, a total of 6,081 patients, or 58.6% of patients, met that metric in 2020, and 5,487 patients, or 57.9%, in 2021. So our goal is 76%, which is a 75th percentile benchmark. So obviously we're falling short of that. And we believe that there are various reasons why we are not performing as well as we'd like in the area of childhood immunizations. And I'll kind of review a little bit of that. Basically, the population of patients we serve are especially challenged by social determinants of health, difficulty with transportations, parents actually getting the children to the appointments, other issues such as food insecurity, which when faced with spending money to get the child to an appointment versus getting food on the table, obviously parents are going to choose the food. Because of these poor social determinants of health, we tend to serve a more transient population. So the parent tends to move around more to different addresses and healthcare organizations. And we find that with that type of moving around, contact information is often outdated, so it makes outreach difficult. And because of these reasons, we are often playing catch up on the immunization schedule. So as an example, if a child should have 2 shots, 3 months apart for a particular immunization, but they missed that second shot because they didn't show for the appointment, they still get the second shot, but now they may be older than 2. Now maybe they're 3 years old. So in fact, even though most of our patients are immunized, it may not be on the schedule that is set forth by HEDIS. So they are immunized, but it's behind or we're playing catch up. So these next 2 slides, we'll go to the next slide. These next 2 slides are a breakdown by health center for quarter 3 and quarter 4. So as you can see here, we know that Arlington Heights, Core, and SingStack are performing better on these metrics. And we're working to duplicate what they're doing with their efforts and scale some of their outreach strategies to other centers. The next slide is quarter 4, and again, very similar information. Next slide, please. So what are we doing to improve our metrics, in particular, the childhood immunizations? So we're really engaging all of our site medical leaders and teams. This is what we've already done. They're starting to do now monthly report outs and action plans. So if you're not meeting target by the end of that month, why not take a look at it with your team, study it, and revise if you need to revise your workflows or how you're strategizing. We are in the process also of developing standardized outreach workflows, and we have also identified local champions at each of our clinic sites for both of these metrics. So in terms of what our next steps are, we recognize that there are barriers. Always not, if you don't have enough staffing, that's going to be a barrier because your staffing might be allocated to do regular workflow in the clinic, rooming patients, vital signs, et cetera, and may not have that time to be able to do the necessary outreach. So we do want to look more at our staffing model and have more staff that can be dedicated to this type of population health. But what do we do in the meantime? We recognize, yes, we do have some staffing shortages, but what can we do? So rather than have all of these be separate workflows, what we're going to now do is start looking at how do we train all the staff and just build it into the day-to-day workflow. So it's not as though we have to say, oh, we have to allocate 1 or 2 staff today to do this outreach. We want to figure out ways to strategize and build it into the daily workflows so that it just becomes habit for all the staff. It's going to take a lot of training, a lot of education, training the staff on the importance of all these metrics and why we have to hit this data. That is it. Thank you.
Well, thank you very much. I think that was enormously helpful. I've understood the diabetes stuff much better than previous reports. So thank you for that, Dr. Aaron.
You.
So that's terrific. Are there any questions from anybody else or any other comments?
Yes, this is Director Harrington. Yeah, I'm just curious to how they're working in coordination with maybe public health and some of the community health workers that are in their system in terms of outreach to the patients. She mentioned the social determinants of health, and that's really related to where people live. And so how are we working to penetrate the community and get people out to work with people and these patients that are challenged with diabetes?
Thank you so much for that question, Director Harrington. That's an excellent question, and that is exactly what we're going to be looking at when we're talking about now building into workflows where it will just become automatic. So we do have CHWs in our system that we're going to begin to leverage to help do this outreach. So again, we're not just having the medical assistants on site, but we're also looking at the CHWs. And we already do have CHWs that are paired up with every health center. And so more to come soon, but we will be building these into the workflows where the CHWs are very much engaged and helping to do a lot of this outreach.
Yeah, and CCDPH has community health workers as well. I think many of them, and actually they got this grant from the CDC, which is focused on COVID, but they will be doing outreach, and their focus is suburban Cook County. But it may not affect our metrics with the hospital, but there may be an opportunity to get them engaged as well.
Thank you. Thank you for that information.
Right. They don't usually use them for clinical work, Director Harrington. They are more for, we use them for contact tracing, and we've been trying to use them for example, lead abatement and some of the other public health functions.
Okay. Other questions? If not, we'll move on to hear about regulatory and accreditation updates if somebody is ready to give that report. Thank you.
Hi, Ciara's here. Good morning, everyone. I'm going to give a quick update for our month of February. We have submitted our CAP update citation action plan on February the 3rd of 2022. We're finally put everything in motion on the final report. The virtual survey for the Stroger American Burn Association re-verification evaluation has been completed. We're currently waiting the final report. We have 3 upcoming surveys as of now for 2022. The Providence CAP survey is pending. We're waiting on more information regarding scheduling. The trauma designation survey for Stroger, it was expected for June of 2022. We have now got that pushed back to the end of the year. So more information coming for that. Our stroke certification survey is expected for July through December of this year. We're working with Joint Commission to get that scheduled. We anticipate it will be the summer. Joint Commission is a little bit behind, but I'll have more information for that. We have also scheduled our newly structured system continuous readiness committee that is scheduled for the month of March, and we'll have more information regarding that. Any questions?
No? In that case, we'll move on to the next item, which I believe is Dr. Kimberly Dixon is going to present an update on geriatric services. And I must personally thank you for putting this together, because I think this was provoked by my questions at a previous meeting on managed care. So please go ahead, Dr. Dixon.
Thank you all for inviting me to speak about our services in geriatrics here at Cook County Health. Is everybody able to hear me okay?
I can, certainly.
Okay, thank you. So we'll talk a little bit about the services our team provides, some quality improvement and safety projects that we're involved with, our productivity and capacity, and some challenges and capacity building opportunities. Next slide, please. So our mission statement is, as you see it, we're an interdisciplinary team which is working to provide comprehensive care to older adults in Cook County, regardless of their ability to pay, with a focus on optimizing their function and independence. And we also strive to teach others in our healthcare system to provide this level of care and service to our older adult patients. Next slide, please. There are 3 physicians and a nurse clinician among us. Next slide, please. And we provide basically 15 sessions per week of direct care. There are 12 sessions of primary care clinic. We provide continuity clinic and some geriatric specific services I'll discuss in another slide. And we saw about 4,400 patients in the calendar year of 2021. And we have 3 sessions a week of consultative clinic. We saw about 190 patients last year, and we absorb up to 1/3 of the patients that we see in our consult clinic into the continuity primary care practice. And then there is some nursing home care provided by one of our clinicians as well. Next slide, please. As you can see, essentially geriatric care is excellent primary care because the majority of adults in the U.S. 65 and older have at least 2 chronic conditions, and you see the most common ones on the National Council on Aging graphic that I've put in the slide. We take care of diabetes, hypertension, and we focus on the whole person in terms of function and quality of life. And we try to work with an interdisciplinary team that's centered on the patient, including usually a family and a caregiver, and the rest of the team members you see here. Next slide, please. So getting to what is specific to geriatrics in the terms of the services we provide to our older adult patients, we work based on the 4 M's model, focusing on mobility, mentation, medication, and what matters. And so in terms of mentation, we're focused on screening for memory loss and dementia and helping patients to manage, and family and patients to cope with the loss of memory over time that can occur. Depression screening is very important in our practice. We know that memory loss can be associated with depression and sometimes gets better if we diagnose and treat depression. Mobility includes not just fall risk assessment, which we certainly do, and we're doing some QI work with that, as I'll talk about in another slide. But we like to focus on their function within their living space, whether it's in the home or outside, and really optimizing that. Reviewing medications with an eye towards optimizing the things that improve quality of life. So treatments for pain, treatments for depression, while minimizing the things that can cause adverse effects that could increase, for example, sedation and risk for falls. And our advanced care planning includes picking a surrogate decision maker or power of attorney, but also thinking about what's important for the management of your chronic illnesses today. And our nurse clinician is bilingual, and she does memory assessments, power of attorney planning, and also disease-specific teaching on self-management of hypertension and diabetes, for instance, in both English and Spanish. Next slide, please. The reasons for referrals, we're housed in the professional building on the Stroger campus, and we're open to all the ambulatory and community health networks. So looking at the year 2021, about a third of our referrals were for memory loss. About another third almost were for the assessment that I just detailed on the previous slide with all the different 4 M's. And a substantial percentage, 14%, were for falls specifically. And then there was a combined 23% that included depression, weight loss, sleep issues. And I should say that many of our patients were referred for more than one particular issue, but this is sort of the breakdown. Please, next slide. And so in terms of our educational activities, our clinic is not just staffed by ourselves as physicians and the nurse clinician. We have physicians in training called residents, and we have them in our outpatient clinic. And one of our physicians, Dr. Illy, also has them go into the hospital, even though we don't have an inpatient service, to do a geriatric assessment on a hospitalized patient, just as part of the learning experience. And it's also been helpful to the medicine teams on the inpatient side. We also provide didactic lectures to the first-year residents, topics such as delirium, dementia, falls, and advanced care planning. Next slide, please. And in the nursing home, Dr. Illy goes to Symphony of the West, which is on the west side of the city, and he manages mostly older adults, but there are some patients, for example, who've had a stroke maybe at the age of 60, who come in for a temporary rehab stay, and he helps manage their chronic medical problems. And he also, during the pandemic, has modified his intervention to include some of the nursing home staff via iPad, helping to do virtual rounds with the patients that are there. He does not take the residents there because of the COVID pandemic restriction, but between the lecture curriculum and the virtual curriculum, I think it's pretty robust. Next slide, please. So quality improvement projects for fall risk reductions. It is standard practice in all of our ACHN clinics to screen 65 and older, patients 65 and older once a year for falls with 2 common questions. And if they've answered yes for those questions, we've tried to intervene and not just have that be data in our system. So as part of the QI project we've done on fall risk reduction, prior to the pandemic, when more people were coming for in-person visits, we had a way for these patients to be flagged by the medical assistants as they had their intake done so that they could be referred by the provider for physical therapy and thus hopefully reduce their risk for future falls. In terms of our upcoming quality improvement plans, one of our clinicians, Dr. Alonzo, trained at University of Chicago and does something called a pill visit. They do something called a pill visit in which they have patients bring in all of their medications, sit with a nurse, and go over them with a lens towards optimizing those things that improve their function and decreasing those things that increase their risk for falls and adverse outcomes. So that's sort of in the pipeline for us. Next slide. And in terms of demand and capacity, the next slide, please. So this is only for the general medicine clinic, and it looks at how many patients over 65 are taken care of overall. And you can see that each year we take care of about 37%, 36% of patients taken care of by all physicians within the general medicine clinic are 65 and older. And we take care of 22% of this population. And I'm not saying that every person 65 and older needs a geriatrician, but I do think that in the gap between 22% that we do see and the 36% that is the total, there is opportunity for better services in geriatrics if we had more staffing. So next slide. So looking at our show rates, they're really quite good. 83% is really good. This is all data as of Monday, February the 7th. So the third next available appointment is a common way to look at clinic capacity and demand for care. And I'm just putting this slide up to highlight that our new patient geriatric continuity appointments, the third next available is 112 days. And our consult clinic, unfortunately, the third next available new appointment is 144 days, with about 54 people waiting for a slot as of Monday the 7th. And this is in contrast to all adults. So adults ages 18 and over are represented in this, the bottom of this table. The wait for the third next available new patient appointment for any age adult is 67, and this includes nurse practitioner slots, residents, and attending physician slots. So there's quite an opportunity if we had more staff, for example. And so next slide, please. One of the things that I want to highlight is that in 2018, we had 4 physicians on our team, as well as our nurse clinician and the social worker. Now, due to a retirement, we're down to 3 physicians. Our nurse clinician is still with us, and the social worker has transitioned to another non-geriatric clinician role within our system. So fewer people, same demand for services. So just wanting to plant the seed that we do have opportunity if there can be growth in our section. We have, on the bright side, posted a geriatrician job position, and we're hoping to be able to distribute that more widely in terms of some of the professional societies, for example. And we're hoping that we can replace our geriatric social worker. We'd also really benefit from having a pharmacist involved, I think, as part of amplifying the pill visit idea and helping us reduce harmful medication use in our patient population. And one of the things that gives me both a lot of optimism and also speaks to the need for more robust staffing is the fact that Illinois, as a state, as of December 2020, expanded Medicaid to immigrants regardless of their legal status, immigrants 65 and older, I should say, who qualify from a financial standpoint for Medicaid. It's not exactly the same as the Medicaid that is offered to U.S. citizens and permanent residents, but it has a lot of features that have been very helpful. So I'd like to end with the next slide, which is a slide featuring one of my patients who's pretty famous in the community. This is Mr. Ocampo. He used to be a paleta vendor, an ice cream street vendor, before his arthritis became so severe. And on the bright side, in October of last year, he was able to get a knee replacement because of the Medicaid coverage expansion. And I am happy to report that at our last visit about a month ago, he was doing really well and up on the little walker that you see in the picture. So next slide, please. So I would like to thank my clinical and scheduling teams for the data and feedback on this presentation, and I'm happy to take questions if there are any.
This is a great presentation. This is Director Prendergast. I think this is just absolutely wonderful. I mean, there's a lot of data to show that fragmentation of care, especially for our seniors, is not a good thing, right? Because we don't want them to have to go over here to see their cardiologist, come back to see, and so I think this is just really great, and I would love to see this grow more. Now, question of the 30, is there in terms of sites, your satellite sites, do you know if there's a higher percentage of eligible patients at, say, one site? Because maybe if we can do a targeted, expansion, looking at maybe if there's one of the centers that may have a higher percentage of eligible patients over 65, that you can look at expanding, or do you have it, broken down by that? I'm sure you could probably get that. As I'm just thinking about, with limited resources, how do we maximize the reach?
Sure, Director Pendergast, I appreciate your question. And again, certainly though we're housed on the main campus, our referral pool consists of everyone in the system. One of the things that has been shown, though, is that in previous years, when we've looked at the data of who 65 and older goes to which HCHA and clinics, I think the main campus has a higher proportion of patients 65 and older than the others. But the last data I've been able to get for that has been maybe 2016, 2017. But just based on clinical experience, I can tell you that especially those older adults who are not just coincidentally 65 and older, but also who have multi-morbidity, who have the hypertension, the diabetes, the COPD, and so therefore maybe they need not just to see a geriatrician or a primary care doctor who happens to be a geriatrician, but they also have a cardiologist, a pulmonologist for their lungs, maybe a nephrologist for their kidneys. They're more likely to self-select to have a primary care doctor here on the main campus. So I think that drives some of the higher percentage we have. I would certainly take the opportunity to touch base with our medical informatics folks and get a more updated count of who's where. But that's my sense is we have pretty high percentage.
But it's also a challenge for us because for some of those folks, the frail elderly, traveling to the central campus is a challenge.
For sure.
And previously, we had a clinic, Woodlawn Clinic, which actually didn't see children, which only saw adults, and was located across the street from a senior center. And the majority of the patients that we saw at that site were indeed seniors over 65.
Sure.
However, due to financial constraints, we closed that site. And I think that's a missed opportunity. But we do also have other sites that are located in close proximity to senior centers. And if we were able to offer these services out in the community, I think we could attract more of those folks for whom traveling to the central campus is a challenge.
Sure. That was my point. Yeah, I think that we could maximize. Yep, that's one way to look at it. Thank you.
Mm-hmm.
Other questions or comments from anybody who's on the call? No? Well, thank you very much. That was extremely informative. I mean, this was absolutely sort of news to me that we had such a highly developed geriatric sort of subsection in medicine. So thank you for that report. And now I'm happy to introduce our Chief Experience Officer, Lynn Dang, and please go ahead.
Good morning. Thank you, Chair Guggenheim. My name is Lynn Dang. I'm I keep saying I'm the new Chief Experience Officer. I've been here 3 months and a half, and I'm still loving it. Everyone here has been great to work with and work for. So my goal, my job is to help improve the patient experience plus the staff engagement. And so I'd like to share a little bit about myself. Please flip to the next slide. Thank you. So my personal goal is to bring back the joy in work and to remember our purpose for working in healthcare. A little bit about myself. I have over 16 years of healthcare experience, and I am proud to say that I was among the first cohort of 70 professionals to earn the certificate, patient experience professional certificate. And while at New York City Health and Hospitals during the pandemic, I was the lead philanthropic coordinator. So we raised over $35 million to support the staff relief effort. And also I've raised more than $5 million towards art initiatives. One of the most successful initiatives was the community mural, which I will share later on. Next slide, please. So what is patient experience? This is a definition from Barrel Institute that they would like for everyone to adapt, and I love the definition. It's the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. And the important thing is the sum of all interactions. So each and every one of us here at Cook County play a huge part in how our patient will perceive their care. Not one person is the secret sauce, but all of us have an important ingredient to bring to that secret sauce. So our mission is to inspire hope and proactively contribute to the health and well-being of patients, families, and staff members by providing compassionate and high-quality care via an engaged and energized workforce that embodies teamwork, respect, communication, and overall excellent customer service. The vision is to be the leading health system that provides an unparalleled experience by creating a model of mutual respect, teamwork, equity, and person-centeredness that brings the best aspects of a care team to every patient and employee. Next slide. So, we are remembered by the problems we've solved or the problems we've created. And under Mr. Roach's leadership, his team is focused on being remembered for the problems we've solved. And so these are the top 4 goals that I would like to focus on for the first year here at Cook County. One is to drive the patient satisfaction scores by performing root cause analysis, offering customer service training, implementing the Press Ganey iRounds apps, as well as conducting wellness rounds, having the CI Care transformation by building a standards of behavior training module, improve the employee engagement for the staff and management by raising up life-giving leaders where they support our staff by opening doors of opportunities to grow and advance within our system, for them to coach our staff to be their best self for our patients and each other, and to mentor our staff on how to problem solve. As humans, we are created to solve problems, and that's when we experience fulfillment, and we want our staff to be able to have that experience. Next, and then we want to have the engagement wellness, where we offer wellness lounge to our staff, and also we have the PFACT established. I'm happy to share that our first Patient Family Advisory Council will happen next Wednesday from 4 to 6 p.m. And also to systemize our operations, where everyone will look at the same document and be able to understand what it means, rather than having all these various reports outside. And then when you share your report, no one knows, or some people may not understand it, so it adds stress to their lives. Next slide, please. So these are the next 2 slides will list the initiatives for the fiscal year 2023, but I'd like to highlight just a few initiatives that could bring back the joy at work. One is the Wellness Lounge programs, where we will provide a space for our staff to detox, to meditate, use that same space for exercise like Zumba or Tai Chi, and also provide some wellness classes such as art making, gardening, and cooking. And then another initiative is to increase our labor and delivery census. I know right now we've had almost 800 deliveries last year, and we are planning on offering some incentives to give for patients who want to have their birth here at Cook County Health, such as offering gift bags with baby onesies, baby blankets, and baby's first book. And not only that, we would like to offer some art initiatives like belly paint projects and also new baby photos as an incentive as well. Next slide, please. And then the other one is community murals. When I was at New York City Health and Hospitals, we had 27 community murals at 5 of the boroughs within 3 years. And this is an initiative that Mr. Roach would like for us to have here as well, is to have 17 murals at 17 of our sites. Next slide, please. So here are examples of the new mom belly paint project. In the middle shows you the steps of how we would use plaster to cover the belly. And then we would have a group meeting with the new moms and just kind of sit and give them prompts as to how to paint their belly. And then they get to keep that as an incentive to have their delivery here at Cook County. Next slide. And then also the baby portraits also as a gift. Next slide. So here is an example of some of the community murals that we did at New York City Health and Hospitals. But the important thing about the community mural is I have seen a shift in the culture at the hospitals that we've had the community murals, and that's something we would like to bring here as well. You know, public health system has this negative stigma towards it, and we want the community to know that they could come alongside us and partner with us. And the community mural is a great opportunity where staff members, leaders, patients, congressmen, and even some board leaders came alongside each other and paint next to each other. So there's no hierarchy, just a group of people coming together to create something beautiful. And it's something everyone remembers. And not only that is when the staff members go into the hospital or patients go into the hospital, they look at the mural and they remember which part of the mural that they painted. So I've had, a staff member says, well, I know that trash can right there. I painted that trash can. So every time I come in, I'm always happy that I painted that trash can. So we're hoping that it will trigger a happy memory every time the patient and the staff members will see the mural that they helped create it. Next slide. And this is, we usually have before and after survey, and this was some of the comments and the data results that we had for the community murals, and I'm hoping that we'll get that same enthusiasm as we did in New York. But the average stress scores decreased by 17%. Average social support score increased by 15, and the average of engagement scores increased by 12. And these are some comments. I've worked here for over 10 years. This is one of the nicest common thing the facility has done for their staff, and especially during COVID times. Please consider doing this or similar projects again. This was a lovely experience. Thank you for helping us transform our painful experience into a meaningful one. Next slide. And the next two slides are just to reiterate why it's important to have an engaged workforce. Happy staff means happy patients. Next slide. And here are the benefits. You get greater productivity, reduces stress, increase morale, and improve resilience. 70% of employees enrolled in wellness programs have reported higher job satisfaction. And then employees are more likely to recommend a company that supports well-being efforts as a good place to work. So I just want to thank you for your time, and I'm happy to answer any questions. I think you're on mute, Chair Guggenheim.
Sorry, I couldn't make my computer work. Yes, I just want to mention that, of course, we had this community mural when we opened the new building a couple of years ago, and that was a sort of terrific community participatory process. And that the Chicago Public Art Group is the great resource on this. You've probably found them already if you've been talking about this. I just want to make sure that's known to you.
Thank you. Yes, so we usually put out an RFQ, but I think you call it RFP here. And then, artists will write to us and fill out the abstract, and we would have the committee help us pick which artist they would like to work with. And so there's this whole process, and we have a focus group. But I also will reach out to the Chicago Public Art Group and see if they have some artists that would like to apply. But we're hoping to start this during spring and summertime, so that we could paint outdoors and be able to do the social distancing.
Yes, because there's a very robust public mural community in Chicago. I mean, there's a long history of doing this stuff with very distinguished muralists. So that's great to know you're thinking about doing that in the health centers. Other comments from people? If not, we will move on to action items, which is item 4 on the agenda. We have no appointments or reappointments for hospital department and division chairs today, but we do have, as usual, the medical staff slates of Yes, Dr. Akintorin, are you going to say something about the Stroger Hospital medical staff action items?
Yes, please. Good morning, Chair and directors. What I have to present is the proposed medical staff appointments, reappointments, and changes for Stroger Hospital medical staff. We don't have a report from the HQPS summary for this month.
Right.
Thank you.
Okay, and I guess we do not. Are you going to present from Provident, Dr. Vegan, or we just have the action items that were circulated ahead of the meeting, do we?
Sure.
Yeah, I didn't receive a request from them, so I don't know if they had anything to report.
Sure. I apologize. I spoke with Dr. Kirby, and he is tied up in clinic, and they do not have an HQPS report, so he is presenting his items, his medical staff items, for the committee's consideration.
Right, and they've been circulated ahead of the meeting.
Yes, that's right.
So we'll hold both of those items for the combined motion. And lastly, the quality and patient safety minutes were presented at the board January meeting. But if anybody has any comment and wants to review or discuss any item or make any correction, now is the time to say. And hearing no comments or seeing no hands raised, I would ask for a combined motion to address the following action items. That's to approve item 4B, the Stroger Hospital medical staff appointments, reappointments and changes, to approve item 4B, Provident Hospital medical staff appointments, reappointments and changes, and to accept the January 20th Quality and Patient Safety Committee meeting minutes. Do I have a motion?
So moved.
Thank you. And it's been seconded. And would you please call the roll, Secretary?
Roll call on the combined motion. Aye or nay. Director Garza?
Aye.
Director Prendergast?
Aye.
Director Story is absent. And Chair Guggenheim?
Aye.
You have 3 yeas and 1 absent.
Okay, so that motion carries. And now we are planning to go into closed session in order to have some reports that are allowable under the following exceptions to the Open Meetings Act. That's 5 ILCS 120/2 C1, 11, 12, and 17. And do I have a motion to that effect?
So
Make a
moved.
motion. Second.
Thank you. And can we have a roll call vote on that, please, Secretary?
Roll call vote on the motion to go into closed session. Aye or nay. Director Garza?
Aye.
Director Prendergast?
Aye.
Director Story is absent. And Chair Guggenheim?
Aye.
You have 3 yeas and 1 absent.
In that case, I'll say goodbye and we'll reassemble in the new meeting in due course. Thank you.
Thank you. Bye.
Thank you.